I'd now like to introduce Dr. Andrew Hendifar, medical oncologist here at Cedars-Sinai Medical Center. He has been really taking care of the majority of neuroendocrine patients at Cedars since I left this institution, and is a wonderful gastrointestinal medical oncologist, and he's really doing wonderful things with neuroendocrine tumors, and as you can see, was also involved, along with myself, with the PRRT program at Cedars-Sinai, and we're really honored to have him today. Thank you.
So today I'll be talking about advances for neuroendocrine tumors, more treatments, more questions. And I'll try to address some of the new issues that are arising in the clinic based on all this hard work that Dr. Wolin and other investigators around the country are doing. So there's no question that the incidence of neuroendocrine tumors is rising. We often attribute this to better diagnostic techniques, but we can't ignore the fact that this is a growing problem. Over the last several decades, we have come to understand a lot about this disease. We understand that they have different grades, they have different biologies. We can accurately predict the grade using Ki-67. We have amazing functional imaging, as well as anatomic imaging that really help us treat and improve and prognosticate. And every year, it seems like new treatment options are being approved and being used. And that's reflected in the improvement in how patients are doing. There's been a dramatic improvement in the outcomes of patients with neuroendocrine tumors, and that's a direct result of all these new approaches. So let's talk about some of the new, sometimes it's good to have new problems, but we have some new problems, new questions that are coming. So one of the most common things we deal with in the clinic is, what are the indications, or when should we start somatostatin analog treatment? Second question is, when should we use this everolimus or this new mTOR inhibitor? When's a good time to do it? Third question often comes up is, how do we sequence these treatments? With peptide receptor radiotherapy, when do we do it? And finally, there's a really new, unique medication that's been approved, that's been discussed earlier today, but how do we implement these new types of tryptophan hydroxylase inhibitors or telotrestat? How do we do that? So one thing that's wonderful about neuroendocrine tumors, let me see if this works. It does. Is that you can target it with somatostatin receptor therapy here, or mTOR inhibition through the AKT-mTOR pathway. Now, somatostatin is a 14 amino acid peptide that inhibits secretion of a broad range of hormones. It acts by binding predominantly to somatostatin receptor subtypes 2 and 5. And we have technology that can identify the presence of these receptors using an octreoscan scan and a gallium scan. Now, when you understand that somatostatin has effects all over the body, you begin to understand why we have certain side effects when we use these treatments. In the liver, it inhibits bile duct secretion and gallbladder contraction, causing gallstones. In the pancreas, it causes endocrine and exocrine pancreatic insufficiency. And the GI tract, it can cause upset. So how do we use them in the clinic? Well, one, we use them to control the symptoms of carcinoid syndrome. There's typical symptoms like we see, the flushing diarrhea. There are pancreatic tumors that are functional, that can produce different hormones that cause problems. And there are also atypical syndromes. And we also use it to control tumor growth. And this is supported by all the national guidelines, including NCCN, North American Neuroendocrine Tumor Society, and the European Neuroendocrine Tumor Society. I think Dr. Wolin had a similar slide, but there's two therapies frequently used. There are more in clinical development. There's octreotide and lanreotide. The chemical structures are similar. The receptor binding is maybe a little bit different, but otherwise these medications are quite similar. The first study that we'll talk about occurred about 30 years ago, reported in the New England Journal of Medicine. This was using octreotide self-injection 3 times a day. So see, in some ways, things have improved. We don't self-inject, and we don't do it every day. This was done for 25 patients, and 22 out of 25 had an improvement in their symptoms. That's a pretty good score. Better than I did in high school, and better than most treatments that we use today. I mean, that's pretty remarkable. Also, 18 out of 25 had a decrease in the urine 5-HIAA levels, which is important. I think it's important. And the duration of response was quite long. This treatment lasted for more than a year. The next important study was the PROMID study. Investigators began to question, well, maybe we can use this to control tumor growth, not just tumor symptoms. In this study, patients with midgut neuroendocrine tumors were included, both functional and non-functional tumors. Pancreas tumors were not included in this study. It looked at the long-acting release octreotide versus placebo, and wow, it made a big difference. It really slowed down the tumor growth. So not only would it help symptoms in patients who had symptoms, but it could also control tumor growth. And I think that was quite remarkable. There it is. And now in the most recent LACNETS study, we see further expansion of the use of these medications. In this study, pancreatic and GI tumors were included for receiving lanreotide. Only non-functional tumors, those that were serotonin receptor positive, and both grade 1 and 2. And again, this treatment was found to improve progression-free survival, meaning it extended the amount of time before the tumors grew. And really interesting was that it worked in all the different subtypes. So here we have the midgut, we have the pancreas. The hindgut was a small group, so I wouldn't think too much about it, but it worked in grade 1, grade 2. And we thought that maybe the amount of tumor in the liver was important, but it seemed not to make a big difference here. So to conclude, for somatostatin analogs, we use it, 1, to control the symptoms of carcinoid syndrome. And also, we can now use it to control tumor growth. We use it for GI primaries or pancreatic primaries, and especially if they have octreoscan positive disease. Now, for lung tumors, is probably the next question that we have to answer. There are several ongoing studies looking at octreoscan positive lung tumors and the use of lanreotide, and we should get answers to that in the future. Next, I'm going to talk about the RADIANT-4 study and the new use of mTOR inhibitors for the treatment of GI neuroendocrine tumors. So it's been approved for pancreas for some time, as we already heard today. And in this study, let's see if I can go back. It was investigated in patients with non-functional neuroendocrine tumors of the lung and GI tract, excluding the pancreas because that was already done. Oh, this is hard to see, huh? Yeah, I should have known. Okay, so let me help out. So the blue line are the patients who had everolimus. The red line was placebo. This is looked at by the investigators. This is centrally, and this is survival. And as you can see, the blue line is better than the red line, so that's fantastic. The difference is quite significant. And you see here's it's called a forest plot when they do these subgroup analyses. It looks like it works for lung and GI, both. And then I think this one, right, here's the unknown primary category in third. So it looks like it works across all subgroups, which is great. Here's a waterfall plot, which is my favorite name for a plot. And you can see here, this means below the line means this is the shrinkage on this side. This is increase. So you see that on the everolimus arm, you had more shrinkage than on placebo. I'm always amazed by how much shrinkage there are in placebo trials. I don't know. I don't know. I think it's amazing. So for everolimus, we use them for non-functional neuroendocrine tumors of the lung. We use them in pancreas tumors, and we also use them in non-functional GI tumors. Now, should we use them in functional tumors? I think it's very appropriate, but we also have other very important therapies too that can also help. So then, how do we sequence? I think this is a very interesting question that we're all thinking about a lot. And I think we're all searching for the secret recipe or the secret sauce that we can write down on a piece of paper and say, okay, if you have a neuroendocrine tumor, it's this grade, this location, these metastases, this is what you do. And we could just write it down and we could hand it out. But I think, unfortunately, it's much more complicated than that. Here you see, if you had a well-differentiated neuroendocrine tumor that's Actria scan positive, I kind of tend to look at it like this, that the backbone of treatment, oh, hold on. Oh, I ruined it. I ruined it, shoot. The backbone of treatment is somatostatin analog therapy. There's everolimus, there's surgery, PRRT, and liver-directed therapy. I didn't put them in any order, so I apologize if anyone's upset at me that there's not on top or whatever. But what do you do? How do you figure out what to do? Well, you ask a neuroendocrine tumor specialist. This is the only picture I could find of myself. Yeah. But not really a specialist. You don't need a specialist. You need really, what you need is a team. So you need a group of doctors that are getting together. You need the medical oncologists. You need the surgeons. You need interventional radiology, GI. And you need to get together in a room. You need to talk about it. And you need to, there's not always agreement, but definitely from the interaction of different specialties, you definitely get to understand and a better idea of what are the pros and cons and what is best for a specific patient with a specific presentation. Okay, so finally, so that's how we sequence. So I recommend for sequencing that if you're having a question about sequencing, you find a neuroendocrine tumor hospital or a team nearby. It's a good opportunity to say hi to Dr. Lee. I saw him from City of Hope. Yeah, he's over there. So they have, there's teams all over. So you find a team, and they discuss it in conference, and they come up with the plan. So here is telotrestat. It's a tryptophan hydroxylase inhibitor. It's a pill, which is really great. It breaks down and decreases the amount of serotonin in the blood. Phase 1 studies looked at it for patients with diarrhea from carcinoid syndrome, and it had a very good benefit in those patients, decreasing the number of bowel movements they had a day. It's always interesting in these types of studies, you have to pick an endpoint. To do research, you have to have some objective endpoint. It can't always be, I feel better, I'm doing better. So that's kind of why they stick to bowel movements. It's pretty measurable, as weird as it seems. Yeah, So then here's a phase 3 double-blind study looking at 2 different doses of telotrestat versus placebo, and again, dramatic improvement in number of bowel movements in patients with carcinoid syndrome. So when is telotrestat going to be used? I believe it'll be used as adjunctively, meaning in addition to, not necessarily standalone. It'll be when diarrhea is not controlled with somatostatin analogs or other conventional means. And I'm really interested to see if these types of medications can do more than just reduce the number of bowel movements. Maybe they'll be improving the quality of life and fatigue. And those are some of the things that are being investigated currently. So thank you very much for giving me your time. Appreciate it.